So we have a few minutes for questions, and perhaps we could have the lights up in the hall so I can just see where they're coming from. And it's a bit of an open question answer. I'm sure that the presentations you've heard have engendered a few questions and queries. I'd be happy to try and field those.
Stuart, can I ask a question, please?
Absolutely.
Sorry, I'm over
Oh,
here.
there you go. Hello. Oh, it's Richard. Hello, Richard.
Hi. Richard Driscoll, can you tell me what happens to paediatric patients' consent when they become adult age? Do we need to reconsent them?
Forms and information leaflets for parents, and I think you will need to reconsent them as adults when they get to 18, and I think there's no harm in, as it were, inviting them to do that when they get to 16, or it's handled in the same way, I think, as the sort of transition issues. But you definitely will need to reconsent them when they become adult.
Okay, that's bad news.
The whole thing can be seen as bad news, but actually I think we also need to see it as a positive, which is that patients are getting informed about what's happening to their data and can feel. And I can only say in other databases, patients have a strong sense that their data that they're giving is contributing to the overall well-being and development of IBD. So I think it's actually very much how this is presented.
Okay, thanks.
Can I just ask a question about the data you showed? Actually had quite wide variation in that the 5-ASA usage is just fascinating, and we could talk about that whole session. And then the admissions, I know David was on telly this morning with the data of patients being admitted, but you think, well, what's an admission? An admission, the patient comes to the hospital, but a visit to having infliximab is maybe not an admission. So are we all counting the same beans as beans, or beans different places, different sizes, different colours? It's all a bit difficult.
John, the data that we presented today is, it's incredibly early. It's desperately crude. All your comments are entirely justified in looking at the data. But the HES data in particular, we sort of told them what we wanted them to do. This is what we got back, and we didn't have a chance to go back to them to refine it again. So
I'm not trying to be negative. I think if we get this right, we'll be able to iron out these things. And I mean, you can save more money than this is ever going to cost us if we rationalise the 5-ASA prescribing across the country. The NHS would be
millions of pounds better off.
We could all have 4 extra nurses. I mean, the gains here are huge. We just need to find a way of making it all work. And there will be some wobbles at the beginning, because there'll be some crazy data coming out suggesting that we now have 8 million more inpatients.
Yeah, and having Keith Bodger's input, who probably understands HES data better than almost anyone else in the country, is going to be critical to maximising the benefit for our patients from the data. So it's early days, but really what I was trying to present today was, technical issues aside, was trying to give you a flavour of what could be done and what the potential of the data is in terms of addressing some really big issues. The 5-ASA question, for example, is one that certainly is in Stuart's mind to try and address at some point in the near future. So
if I can add something there, I mean, one of the analyses, for example, that we'll be able to do with HES data is linking up the different sets. So we will be able to link up the information in the A&E HES data set with the outpatient attendance data set. So you will be able to look and see what proportion of your patients had an emergency admission so an attendance at A&E and hadn't had an outpatient attendance in the previous 12 months, for example, which begins to look at those issues about the sort of quality of care that's being provided. But we're going to have to work out, issues around the sort of quality of the data, the meaningfulness of the coding, and then develop a structured framework of analysis that actually contributes both to the sort of national perception and to provide, valid benchmarking.
Thanks for the questions. Good. Microphone 1, Miles Parks.
Stuart and Fraser, congratulations to all of you for the huge amount of work that you've put in to get this out of the blocks. My question relates to how you're going to handle hospitals where there are already electronic recording systems which we're obliged to use. Is there going to be a means, is this the system which Matt referred to of sucking data over into the registry, can that remain a live system for other hospitals where they've, we're just setting up a big EPR at the moment in Cambridge, which we're going to be obliged to use. We don't have any choice at all in that. All the hospital billing comes out the back of that and everything like that. But if we can get the link right, I would hope that we might be able to keep that link live and use that as a means just of sucking the data out constantly into the registry. Do you anticipate that that will be possible?
Completely. I mean, it's just we've been defining the data export framework at the moment with HSCIC. Obviously, we need to make sure that the data that you're extracting from your trust is the same as the data that's been extracted from other trusts. But you know, it's just a case of working locally with your IT departments and ensuring getting the data exports right. And I see no barrier to that moving forward. But it's just making sure it's apples and apples and oranges is the challenge, I think, in that.
And just to add, in terms of the uploading of the data, it'll be done by HSCIC through their secure portal, and it won't matter to them whether you're a PMS user, registry PMS user, or a user of a different system. They will just be receiving, exactly the same outputs, and that's what. So the data specification for this is with them for approval at the moment, and we released, I would hope, within the next sort of couple of months.
So it might actually be at that level that the data integration actually happens at the HSCIC. Yeah, thanks.
Thanks. Microphone 2.
Stoke. I think we're on the list of about to go on. We've been told we've got the funding and everything. But we also have a very slow IT services, and I know in a lot of other areas we've had issues, so I can just anticipate. Who do we actually contact if we're in this area where we're having problems? Because we're very keen to be involved, and I just wondered, because I think it will be me that people will link with.
I mean, one of the things that we've recently done through the Standards Group, actually, which had the backing of Mike Glynn, was write to the chief executives of trusts to say, actually, this is a really important piece of work. It's fundamental to us in terms of driving up standards. So, I mean, I think that if there are particular trusts where you do come against those issues, then talk to us. We can maybe just send another letter to your chief exec. And we've got Birmingham, for example, have said, yes, let's talk. But I've also heard stories of a chief executive that's just passed it back to the gastroenterologist and say, hey, I'll sort this out. So I'm sure there will be real variations, but certainly if there are, if you do come against those roadblocks, if there's things that we can do from a standards and a registry point of view, I'm sure that we'd be very happy to do that.
So if you ring Simone Court at the BSG, there is a mechanism for her to feed back trusts that are having problems to the exec committee, and we have, as David says, a few workarounds that we can hopefully use to help. Anybody else? Do I see John Williams? Hello, John.
First of all, congratulations on huge achievement. Fraser, the link to HES, did you look at how concordant the diagnoses were in the registry and with those held in HES?
Yeah, you would have seen a chart illustrating that, I think in keeping with work that Keith Bodger has done, that I think there is a discordance of about 25%, which has been recognised before. I think, it's something that we have to work with. We have to get better at the coding. We have to get better at our interaction with HES. Again, the analysis that we have so far is desperately early, desperately preliminary, and I think with a bit of refinement, that will get better and improve. But HES data is what it is, and what we are having, we're just trying to get the most out of it, because, as you say, it's critically important for the running of health services and hospitals, and so if we're using that to the benefit of our patients and our services, then it's a powerful tool.
So it's a good opportunity to try and influence that data quality. The second question was, I got the impression that many patients had comorbidities from what you showed on the HES data. Do you have a feel for how many of those would also be the subject of a registry, and whether that's going to be a problem in the future?
What, for other disease registries?
Yeah.
No idea at the moment, I'm afraid.
It's an issue we'll have to address. We can't be putting patients into multiple registries.
I saw that data this morning and thought the same thing, but it's very early days. We just haven't had a chance to actually look at it in more depth, but it's something we're going to be looking at.
So, John, just to come back from discussions I've had with Health and Social Care Information Centre on this, one of the developments that they're looking for is the ability to just actually, in a sense, have a central index of which patients are flagged on which registries. so that one can begin to identify. And so, for example, we've started talking to the bowel cancer audit and about the possibility of precisely that, so that we can identify which patients are represented in both.
It reflects the need for what I know is your ambition, which is to collect data at the point of care as part of the routine process of care.
Yeah.
Before we finish, I'll just leave you with these two slides, really, which give you a snapshot of where we are. I don't know if you can see, but there are 4 trusts here which are bolded, which are the trusts that are actively recruiting. Otherwise, it's a traffic light system. There's the 3 pilot sites. The green sites here, with about 10,000 patients, are the sites that are almost ready to go. They're either they've ordered the system, it's being installed, or they're about to start entering. The orange sites, which extend onto the next page, constitute, they have about another 40,000 patients between them. So we have the potential in the next year, if most of these were to come on board, of reporting on a substantially greater number of patients than our amount to date. So hopefully, this time next year, you'll see a much larger, much more comprehensive set of data presented with some clinical hypotheses which we're already working on, and hopefully demonstrating that this data can be put to good clinical use. There's one more question I didn't see because of the lights. Yes, please, go ahead.
No, I thought, I'm Rafiq Mohammed from Birmingham, pediatric gastroenterologist. Our name came up a few times. I just want to say, I mean, I thought it was very supportive of the registry team because we had few difficulties initially. Last year in BSG, when we came, I went back and told the management it's £15,000 is the cost. But our IT added up a server cost, it sort of became 30,000 and higher up. So I rang Claire, and I think you have emailed me. It was good support, and that our IT department took on, and that helped us to reduce the cost. So we have placed an order, and I have to say the SIMS team is very responsive because we have some specific requirement of installation. I only had to talk to them yesterday, and the first meeting is set up for installation. So if anybody is doubtful that whether the process is difficult, it may be difficult to start with, but with the support people receive, I believe this would work out very well.
Well, that's marvellous. That was not a planted question. So with that ringing endorsement in your ears, we shall send you away and invite you back next year to see where we've got to then. Thanks very much, everyone.